Thank you very much. Now we'll talk about the carpal tunnel syndrome. Yesterday we stopped our discussion at carpal tunnel syndrome. Remember, if the examiner is talking about obesity or hypothyroidism or patient who is pregnant and patient who has got end stage renal disease and is on dialysis, you will have to understand that if there is a tingling and numbness in the first 3.5 digits, it is carpal tunnel syndrome until otherwise proved, please. Most of the times it is basically presenting as weakness of the thumb, that is adduction and opposition. If median nerve is involved, the most important sign on inspection you see is wasting of the muscle. What muscle is it? It is the thenar eminence that is prominently wasted in median nerve injury or median nerve palsy. How do you confirm carpal tunnel syndrome? When we confirm carpal tunnel syndrome, it is basically by the nerve conduction studies. The examiner would love to ask about the treatment. First thing is wrist splinting, because it possibly can make the patient comfortable by resolution of the symptoms. And then if the wrist splinting is not working, it is glucocorticoid injection. And if it is severe symptoms, you'll have to make sure that the patient has got a surgery. Sometimes the examiner can also ask about a differential diagnosis such as median nerve injury secondary to brachial artery cannulation. What happens? This is usually the common scenario we find in real life. Sometimes the needle can directly do the laceration, or because of the hematoma, there can be compression. Whenever there is compression of the median nerve, it is basically the sensory deficits that are usually seen in the acute phase, followed by laceration. Whenever the patient has got injury to the median nerve, it is motor deficits along with the sensory deficits we usually see in this patient. Next, we talk about claw or hammer toe deformity. Basically, whenever claw or hammer toe deformity is seen, it basically indicates that the patient has got chronic disorders of the foot. Sometimes patients with the chronic disorders which is affecting systemically can also develop claw or hammer toe deformity. Most of the times it is the diabetes, and sometimes it is Charcot-Marie tooth disease, where contractures can be seen but not claw or hammer toe deformities are seen. It is the diabetes which causes peripheral neuropathy that can cause claw or hammer toe deformities. Rheumatoid arthritis can also be one example where you can find claw or hammer toe deformities. Diabetic neuropathy and foot deformities, we already discussed it. Please make sure whenever there is diabetic neuropathy, Charcot joint needs to be ruled out. All right. Next, we talk about Morton neuroma. The examiner classically mentions there is numbness or pain in between third and fourth toe. Usually, the patient is an athlete, or patient can be a bus conductor or a ticket collector wearing shoes, walking, and is basically a laborer walking on hard surfaces. These are the most classical examples where Morton neuroma can also be seen. Sometimes wearing tight or heeled shoes can also be a cause of Morton neuroma, please. All right. The most important physical examination finding is pain is reproduced by the lateral compression of the metatarsal head. Sometimes we call it as Muddler's sign positive if the patient has got palpation of the third metatarsal interspace, that can cause crepitus as well. Please do remember that is very important. Usually this is a step 1 question. Common plantar digital nerves are involved where neuroma is formed in these nerves. All right, this is called as Morton's neuroma. Next, we talk about fibromyalgia. Whenever there is fibromyalgia, usually the patient has got associated mental health issues. One important thing you will have to remember, please, whatsoever. And the examiner can tell about the patient having widespread pain. That is, patient can present pain in any part of the body. But on examination, you will find tenderness points in patients who have got fibromyalgia. Please to remember that patients can mention that patient usually feels tired all the time and usually have got unrefreshing sleep. Unrefreshing sleep is seen in fibromyalgia and also seen in obstructive sleep apnea. Very important, please. There are tender points on mid trapezius, lateral epicondyle, costochondral junction, and greater trochanter. Usually in fibromyalgia, when you investigate, there are usually normal inflammatory markers and serological markers. How do you treat the patient? It is basically educating the patient, and the examiner can also talk to you about aerobic exercises. As these patients develop fatigue, most of the times sleep needs to be addressed. So, good sleep hygiene. Sometimes tricyclic antidepressants and duloxetine can be used as a patient can be used for patients who has got fibromyalgia. Sometimes there can also be score where the examiner can tell you, or you can usually see these are the things where the patient usually has been affected. The severity scale is 0 to 12, and if it is 3, it is severe. Remember, pain can be present anywhere, please. You need not remember this one. Pain can be present anywhere, but I would say this is one thing you'll have to remember: fatigue, unrefreshed sleep, cognitive symptoms, and you'll have to ask the patient, is it none times, is it few times, is it moderate, and is it many times? This is one thing you'll have to remember, please. Symptom severity scale, please. All right. Next, we talk about polymyositis. Whenever there is polymyositis, it is itis, inflammation. So there will be increased ESR and there will be anti-Jo1 antibodies that are positive. Polymyositis usually is seen in women, and basically the patient presents with difficulty climbing stairs, or he has got proximal myopathy where the patient finds out difficulty getting into and out of a low chair, or he uses his arms mostly to get out of a chair. One important thing, please. Polymyositis is usually associated with involvement of esophageal. Striated muscles are involved. That is why patients can have dysphagia as well. All right. Muscle biopsy, when you see that there is inflammation, so it usually is associated with dermatitis, but most of the times it is not associated with cancer. It mimics as dermatitis, but it is not associated with cancer or any other skin manifestations. Biopsy, when we do it, it is again the necrotic and regenerating muscle fibers we usually see. Treatment, you'll have to give steroids whatsoever. If the patient has got steroid non-responsive, you'll have to go with methotrexate. If it is dermatomyositis, please do consider cancer screening. If it is polymyositis, it can also be associated with paraneoplastic syndrome, but please do remember dermatomyositis is one important condition rather than polymyositis associated with cancer. Next, we talk about dermatomyositis, anti-Jo1 antibodies and anti-MI2 antibodies, anti-helicase antibodies is positive in dermatomyositis. We understood that there is Schall sign, heliotrope rash, Gotran's sign on the knuckles, but please do remember this is associated with the malignancy. Yesterday, I was talking about a real life case scenario where patient has got anti-MI2 antibodies, which usually is presenting with dermatomyositis. Remember, the patient can be presenting with ovarian cancer, lung cancer, pancreatic cancer, stomach cancer, colorectal cancer, and non-Hodgkin's lymphoma. The usual thing is examiner wants you to rule out underlying cancer associated with dermatomyositis. Next, we talk about the clinical features of dermatomyositis. Again, it is a proximal muscle weakness with weakness in both upper limbs and the lower limbs that are equal. Plenty of signs can be seen. Heliotrope rash, Gotran's papule, Schall sign can be seen. The extramuscular findings, it is usually the interstitial lung disease that the examiner can ask you. Sometimes with the raised troponin levels, it can be myocarditis as well. Then we talk about the diagnosis. There will be increased creatinine phosphokinase, increased aldolase, increased LDH, but increased CK is most important thing. Anti-Jo1 and anti-MI2 are most certainly positive in dermatomyositis. Again, it is an inflammation, so treat it with glucocorticoids. Next, we talk about myotonic dystrophy. If there is myotonic dystrophy, family history is predominant. There will be trinucleotide repeat sequences that are present in myotonic dystrophy, usually the CTG repeats that are present. Presentation is usually identified by complete examination, please. There can be temporal baldness, there can be cataracts, there can be delayed muscle relaxation. If you give a shake hand to the patients with myotonic dystrophy, you will not forget that shake hand. The patient has got delayed relaxation of the muscles in the arm or the hand. So patients usually has got prolonged handshake. Sometimes it is associated with the cataracts. Most of the times the death in myotonic dystrophy is basically because of arrhythmias. How do you diagnose it? It is genetic testing and the treatment is address the symptoms. Next, we talk about paraneoplastic syndromes. Today, I have seen a patient with myasthenia gravis, but she is also mentioning autonomic symptoms. When we checked, the patient has got dry mouth. So what did we do? We've sent anti-acetylcholine antibodies, anti-musk antibodies, and also VGCC, voltage gated calcium channel antibodies as well. If you want to consider that this patient with myasthenia gravis, if there is only ocular myasthenia gravis, you will have to send sensitive myasthenia screening as well. Most of the times anti-ACH can be positive, but generalized myasthenia gravis, it is usually associated with thymoma. If the patient's thymoma has been removed but still the patient's myasthenic symptoms are being recurrent, even though the patient is on steroids and pyridostigmine, you will have to understand that there can be recurrence of the thymoma or the patient might be having thymic cancer. That is one important thing you'll have to remember in myasthenia gravis. Obviously, you know that there can be fatigability, there can be diplopia. On sustained case, there is worsening ptosis. All these things you can find in myasthenia gravis. We already discussed in neurology that myasthenia gravis, the reflexes will be normal. Whereas in Lambert-Eaton syndrome, the reflexes will be diminished. It is one thing you'll have to remember. And upon repeated testing, you will notice that the patient has got improvement in Lambert-Eaton syndrome. All right. Dermatomyositis, polymyositis, we already discussed. Next, we talk about giant cell arteritis. Please do remember, whenever there is giant cell arteritis, patient must be age more than 55. Usually the examiner gives you about a 65-year-old patient presenting with headache and pain while chewing, that is jaw claudication. It is giant cell arteritis until otherwise proved. Make sure that you check the ESR, because most of the patients with the giant cell arteritis do have classic elevation in the ESR, and you will have to treat it with the high dose steroids. And why? To prevent the visual loss because of the anterior ischemic optic neuropathy from arteritis that the patient can develop. Examiner can also talk to you about a sudden death in patient who has got giant cell arteritis. It usually mentions, or it is usually because the patients can have aortic aneurysm that the patient can develop in giant cell arteritis. Sometimes there can be pain early morning pain, usually associated with the hips and shoulders, in association with headache and jaw claudication or visual symptoms. It is temporal arteritis or giant cell arteritis until otherwise proved, please. On examination, the examiner can tell you that the patient has got a decreased pulse over the temporal regions, or there is a palpable temporal artery. That is what you'll have to remember, please. All right. Next, we talk about polymyalgia rheumatica. Whenever there is polymyalgia rheumatica, I want you to treat it with low dose oral glucocorticoids. One important thing or one important association with polymyalgia rheumatica is you will have to differentiate this patient from avascular necrosis. I know this is not commonly a differential diagnosis, but the patient can present with the pain in the left hip with the stiffness, not responding to analgesics. Patient has got steroid use. So polymyalgia rheumatica versus avascular necrosis needs to be ruled out. Polymyalgia rheumatica usually affects the shoulders and hips. Patient presents with weight loss. Most of the times it is female patients who develop polymyalgia rheumatica. ESR is elevated and temporal biopsy can be done if the patient has got any symptoms of giant cell arteritis. All right. Most of the times it is age 50, subacute to chronic onset, morning stiffness, fatigue and fever with ESR slightly elevated but less than the temporal artery arteritis. Management is low dose glucocorticoids. That's one thing you will have to remember, please. Next, we talk about Takayasu arteritis. It is also called as pulseless disease, mostly because the large vessels are involved. Large vessels are involved. That is why it is called as Takayasu arteritis. Takayasu arteritis, the initial symptoms are fever, arthralgia, and weight loss. Most of the times, it usually affects the subclavian artery. That is why the patients develop the pulselessness. So, pulse deficits can be seen. There can be stenosis or there can be vasculitis. That is why the blood pressure differences can be seen. And Takayasu arteritis, there can be anemia with elevation of ESR. Most importantly, there can be dilation of the aorta. So, X-ray shows mediastinal widening, please. If you want to diagnose Takayasu arteritis, the problem here is we cannot do biopsy of the arteries of the large vessels because there can be risk of rupture. So what do? You basically make sure that you do a CT scan or an MRI to rule out the aneurysms or to rule out the narrowing of the arterial lumen. Sometimes there is an MRI called vessel wall MRI to find if there is an inflammation going on in Takayasu arteritis. The treatment is glucocorticoids needs to be given for patients with Takayasu arteritis. All right. Next, we talk about the difference between polymyalgia rheumatica, polymyositis, and fibromyalgia. We all know that fibromyalgia is usually widespread pain with association of anxiety, depression as well. So, more than 3 months of symptoms with widespread pain, you'll have to consider fibromyalgia. Usually, there will be normal ESR and CRP in fibromyalgia, whereas polymyositis and polymyalgia rheumatica, there will be elevated ESR. In polymyositis, you will find that there is anti-Jo1 antibodies that are positive, and on biopsy, endomysial infiltrates with patchy necrosis is usually seen. Patient is usually a middle-aged female presenting with proximal muscle weakness. Next, we talk about polymyalgia rheumatica. We already discussed this. We'll have to start the treatment with low-dose glucocorticoids. If there is any association of giant cell arteritis in polymyalgia rheumatica, you will have to treat it with high-dose glucocorticoids. Paget's disease of the bone usually presents with pain, and whenever there is Paget's disease of the bone, it is only the ALP that is elevated, and for the diagnosis, it is usually frontal bossing is what the examiner can give you. So whenever there is frontal bossing, there will be increased hat size or there can be increased cap size of the patient. All right. If the Paget's disease is usually involving the skull and femur, it is usually the bone pain or headache the patient presents with. It is because of the abnormal osteoclastic activity that causes disorder in the bone. So there is osteitis deformis, this as a other name. Long bone, so bone pain, and cranial bones increased head sides presenting with headaches and cranial nerve palsies. Is one important thing you will have to remember. Please do remember that whenever you take an X-ray, particle thickening is very, very, very important in patients with Paget's disease because that's a characteristic sign from which you can directly tell that this patient has got Paget's disease with elevation of ALP and X-ray sign. Now comes the treatment. Asymptomatic, do not do anything, but if it is symptomatic, you give bisphosphonates, please. All right. Next, we talk about avascular necrosis. Please do remember whenever there is avascular necrosis, patient will be steroids. Patient will be on steroids, or patient can be having malnutrition, or patient can be having immunocompromised, such as alcohol use, or can be associated recurrent multiple thrombi conditions such as SLE, antiphospholipid antibody syndrome. Most of the times, the examiner will give you a question saying that the patient has got renal transplant or any transplant organs, and now the patient develops pain in the hip. What do you think of? Avascular necrosis is one important thing you'll have to remember. If the patient has got normal lab count, normal WBC count, normal ESR, and normal CRP. Usually the X-ray is normal. That is why the examiners will tell you that the X-ray is normal. Radiological imaging crescent sign is seen in advanced stages, and MRI is the investigation of choice, please. All right. Next, we talk about age-related Sika syndrome. Please do remember that patient is an elderly 80-year-old female or a male patient associated with the dry mouth and dry eyes. Examiner can tell you that there is decreased blink rates as well. Most of the times, the associated conditions could be diabetes mellitus and thyroid disorders. So you'll have to screen for this if you are diagnosing Sika syndrome, please. The treatment is artificial tears and cyclosporin drops, please. Next, we talk about other causes of dry eyes and dry mouth, usually radiation exposure associated with history of cancer, graft versus host disease. The examiner will tell you that the patient is gone for transplant, organ transplantation, and because of the infections, hepatitis C, it can also be associated with the dry eyes and dry mouth. And then autoimmune conditions can also cause dry mouth, please.
Sorry, did you say treatment for age-related Zika is artificial
Age-related.
tears and cyclosporin?
Artificial cyclosporin drops, because cyclosporin drops can increase the tear secretions. Usually this question is not asked because most of the times artificial tears improve the patient's condition. But please do remember cyclosporin drops as well, please. They can increase the tear secretion and can be used in patients who are elderly. Next, we talk about secondary amyloidosis. Please do remember whenever there is amyloidosis, there is organomegaly and there is enlargement of the tongue. Most of the times, enlargement of the tongue can be seen in acromegaly and secondary amyloidosis as far as USMLE is considered. Secondary amyloidosis is possibly because of the undigestible protein deposition that leads to secondary amyloidosis. I'll tell you one concept here. Basically, most of the times it is the alpha pleated structures that are present in our body. Whenever the protein is usually alpha pleated structures. The enzymes which we generate are usually enzymes which can degenerate this alpha pleated structure. Most of the protein, the DNA translation and transcription usually produce transcription and translation uses produces enzymes and proteins and enzymes which are alpha pleated. These alpha pleated structures can only digest alpha proteins or alpha structures. That is why there will not be any deposition. What happens whenever there is a abnormal extracellular protein that is deposited? It is usually in a beta pleated structure. Most of the times, whenever there is any deposition that is accumulating, it indicates that it is a beta pleated structure. Most of our enzymes are alpha pleated and can diagnose and can digest alpha pleated structures. But what happens, say for example, if it is a non-digestible suture, or if it is a non-absorbable suture, or if it is an absorbable suture, absorbable sutures are alpha pleated structure. So our enzymes which are made from proteins which can explicitly produce this alpha enzymes, these alpha enzymes can go and eat away or can digest the suture material. That is why it is called as absorbable suture. Coming back to non-absorbable suture, that non-absorbable suture has got a beta pleated structure, but our enzymes are oriented to alpha pleated structure. That is why our enzymes are not able to digest the beta pleated structure in the non-absorbable suture. That is why non-absorbable sutures are not absorbed, whereas absorbable sutures are absorbed. Now remember this concept for your life, and whenever there is an extracellular deposition of any insoluble fibrillary protein or any insoluble protein, you must recollect this concept of alpha pleated enzymes and beta pleated enzymes, please. It is very important. Most of the times, inflammatory arthritis, any infections, chronic kidney disease, chronic problems can lead to deposition of the fibrils, that is usually leading to secondary amyloidosis. The clinical presentation, it is organomegaly of all the organs and organ damage as well. Most importantly, the manifestation we can see is a renal damage presenting as proteinuria or nephrotic syndrome. Other organs are enlarged. Hepatomegaly, cardiomegaly, nerves are involved, sensory motor neuropathy, macroglossia, blood vessels are affected, bleeding, dialysis, and there can be skin that is affected, which causes waxy thickening and easy bruising. So how do you diagnose this? You will have to do an abdominal fat pad aspiration biopsy. How do you treat secondary amyloidosis? It is treating the underlying chronic condition we will have to consider in treatment of secondary amyloidosis. All right. Next, we talk about neurogenic versus vascular claudication. Neurogenic claudication is basically also called as pseudoclaudication, whereas vascular claudication is usually affecting the vessels. That is why patient will have pain that is relieved with the rest. Very, very, very important. Neurological claudication, patient is got flexion or symptoms depending on the posture and associated with the numbness, please. Examination on neurological claudication, there will be normal pulses, whereas vascular claudication, there will be decreased pulses. How do you diagnose neurological claudication? We already discussed, whenever the patient has got neurological symptoms, it is usually the MRI of the spine that we will have to consider. Vascular claudication, it is the ankle brachial index that we will have to consider, please. Most important topic in rheumatology is cryoglobulinemia. Remember, type 1 cryoglobulinemia is associated with lymphoproliferative disorders or multiple myeloma, whereas type 2 and type 3 is associated with infections and autoimmune disorders. Infections, when I say, it is hepatitis C virus and systemic lupus erythematosus, the inflammatory or the autoimmune condition we will have to consider, please. Chronic hepatitis C, and most of the times it is HIV. If the patient is immunocompromised, they can develop cryoglobulinemia. I want you to understand, in order for you to differentiate if it is a proliferative or a malignancy associated cryoglobulinemia or infection associated cryoglobulinemia, it is usually the complement levels that vary. In infections, it is low C4 levels that are seen. In complements, it is the normal. In type 1, it is the normal complement that the patient can be seen, please. Sometimes the examiner can tell you that the patient has got recurrent headaches and transient neurological symptoms associated with the tingling numbness resolving after 20 to 30 minutes. You will have to consider hyperviscosity syndromes as one of the most important cause, please. Most of the times there is some condition called binge steal syndrome. Very important. The examiner will not ask you about the syndrome, but please do remember binge steal syndrome is a condition which is associated with Waldenstrom's macroglobulinemia. This IgM, which is a large antibody, usually gets accumulated in the vasculature of the central nervous system. Whenever there is accumulation, the patient usually have hyperviscosity syndromes that leads to blurring of vision, headache, or transient neurological conditions. Same with the cryoglobulinemia as well. There can be hyperviscosity that is seen, but the complement levels are normal. In cryoglobulinemia, if it is associated with type 2 and 3, palpable skin lesions are usually seen. Leukocytoclastic vasculitis is what we commonly call as. All right, next we talk about mixed cryoglobulin syndrome. Whenever it is mixed, it is usually affecting both small vessels and medium vessels, and then the patient can also have systemic findings such as involvement of the skin, involvement of the bones, involvement of the renal organs as well. Fatigue, non-blanching rash, hematuria, proteinuria are usually most commonly seen. But the examiner can tell you that mixed cryoglobulinemia syndrome is usually associated with the two most important conditions, because this is usually type 2 and type 3 cryoglobulinemia. So HCV, HIV, and SLE are the most common associations of mixed cryoglobulinemia. Whenever there is mixed cryoglobulinemia, there will be low complement levels as well. All right. You will have to treat the underlying condition. Calcinosis cutis, we already discussed. Calcinosis cutis is basically deposition of calcium and phosphorus in the skin. It is painless and can present as whitish papules or nodules, usually present around the ear lobes, please, or around the fingertips. Next, we talk about erythema nodosum. Whenever there is erythema nodosum, the examiner can talk to you about HIV infection or streptococcal infection or patient with herpes infection or histoplasmosis or patient has got inflammatory bowel disease. These are the conditions usually associated with erythema nodosum, and the examiner can tell you that the patient has got painful skin lesions. That's it. This is what the examiner can tell you, and they want you to identify what the condition is. It is erythema nodosum, please. Usually it is because of the hypersensitivity reactions to the antigen associated with multiple conditions. Basic lab test will have to do anti-streptolysin O antibodies, TB skin test, and chest x-ray can also be done. Next, we talk about Whipple's disease. Trophirima whippli is the causative organism for Whipple's disease. It is associated with steatorrhea, flatulence, and abdominal distension. We all know that abdominal symptoms are common, but I want you to understand that whenever there is Whipple's disease, usually joints are involved, there will be lymph nodes, there will be nervous system involvement as well, along with abdominal symptoms. So the examiner can tell you that there can be opsoconus myoclonus as well. There is characteristic nystagmus as well. Myocardium is usually affected. Examiner will ask you about the diagnosis. You will have to make sure that a biopsy needs to be done. And in step 1, the examiner can ask you, the intestinal biopsy shows what? It is the positive macrophages at lamina propria, and there can be non-acid fast gram-positive bacilli usually seen in the lamina propria, that is diagnosis of Whipple's disease. Talking about the differentials of Whipple's disease, it is Mycobacterium avium intracellular infection in HIV that usually presents with fever, diarrhea, and weight loss. Very, very, very important, because these are also PAS positive macrophages. but there is no bacilli that is seen. If there is bacilli that is seen, it is Mycobacterium avium intracellular. If there is bacteria that are seen, it is Whipple's disease. If there is no bacteria that is seen, that is Mycobacterium avium intracellular. All right. Next, we talk about causes of secondary bone loss. Please do remember malabsorption. The examiner can tell you that the patient has got prolonged fasting, ITU, prolonged hospital admission. Patient is on steroids. Patient has got long hospital admission, and the patient is on NG2. The patient can develop diarrhea, weight loss, and decreased hydroxyvitamin D and decreased urinary calcium can be seen in malabsorption. If the patient is talking about hyperthyroid features, that can also cause bone loss, but the patient will characteristically be presenting with a tremor in hyperparathyroidism. Hypercortisolism, again, the examiner can tell you about Cushingoid features with hypertension and hyperglycemia. Here comes the most important thing, hypercalcemia presenting as hyperparathyroidism presenting as hypercalcemia can also cause bone loss. Inflammatory disorders presenting with joint pains, morning stiffness, rheumatoid arthritis, increased ESR can cause bone loss as well. Hypogonadism, again, patient has got hypothalamic abnormality. Malnutrition is the most important cause. Anorexia nervosa is the most important cause for bone loss. Multiple myeloma, patient presenting with night pain, renal functions abnormality, anemia, and calcium abnormalities, that is crab feature. It can also cause bone loss. All right. With this, we complete our musculoskeletal system. I'll see you tomorrow with the next system, please. Thank you very much.
Thank you so much.
Claudine.